So, good evening, everyone. This is Dr. Satya Yadav from Society for Pediatric Cell Therapy and Transplant, SPECT. And we have another great session lined up for you all on graft versus host disease, which is a common complication after transplant. And sometimes it can be fatal. And at other times, when it's chronic, it can be really affect your quality of life and a lot of other things. So, this session will be chaired by Professor Pankaj Abrol. And Dr. Pankaj Abrol is a senior pediatrician and PHO chapter member who is currently working at Narayan Hridayalaya Hospital in Gurugram as head of pediatric hematology oncology. And previously, he was at SGT Medical College. And prior to that, for many years, he was head of pediatric hematology oncology at Rohtak Medical College. So, sir, welcome you to this meeting and thank you for being here as a chairperson. Kindly take over the meeting, the next session, and introduce the speaker. Thank you, sir.
Thank you, Dr. Yadav, for the nice words about me. Very happy to come here and chair the session. So today we'll be talking about the GVHD, which is a major challenge in stem cell transplant. And to start with, we'll start with prophylaxis. For that, to talk about that, we have an amazing speaker with us, Dr. Prasad here. If you read, he's working in Children's Blood and Cancer Center, Singapore, which is a part of KKW, Women and Children Hospital. And he's a faculty in 3 medical colleges, National University of Singapore. And his main interest is in precision medicine, stem cell transplant, and cellular therapy. So we are very lucky to have him as a speaker today. And this is an area of his interest. So I welcome Dr. Prasad.
Thank you very much for the very kind introduction. I don't know whether I deserve any of those nice words. Thank you to Satyendra and Dr. Satya from SPECT for inviting me to give this talk. I hope you can hear me. So the first slide is important. The most important part in that first slide is in yellow. It says that I'm a lifelong learner. There are lots of people in this audience who probably know a lot more about GVHD than I do. But this topic, when I was given this topic, it forced me to read. So I did read a lot and I hope to share some of it with you. But the pitch of this topic will actually be aimed at junior people. So please, if there are seniors here, please help me correct if there are any mistakes from my side. There is a vast amount of information and I will try to summarize the data out there. This is the content of the talk. So I will talk briefly about why it is important, what is the history. There will be a lot of pathophysiology in this because it is important to understand pathophysiology, to understand how we're going to prevent and manage GVHD. Prevention, again, is the most important component of how we do transplants in terms of GVHD, especially in the benign bone marrow transplant patients where there is no benefit of this alloreactivity. I will discuss key papers and some take homes. I will talk about B cell depletion, which is what we do here in Singapore. I will also talk about future avenues for therapy, including cell therapies for GVHD that are coming very briefly. So without further ado, this is the first slide I wanted to show. When you search PubMed and say GVHD, you will get about 21,000 hits. Then you go on to revise it to say, I want to know about GVHD with what is latest available in the last 5 years. You get nearly 5,000 hits. And if you further decrease it to say, I want to know about GVHD, I want to know what's happening in the last 5 years, and I want to have only data from children, you get more than 1,000 hits. So all in all, we can say that we are drowning in information yet thirsting for knowledge. That's so much literature out there. So first of all, why does GVHD occur? I mean, Billingham in 1966, I will come to that, said all these points, right? That you have a graft that invades and that cannot be rejected. You have cells from an allogenic donor that sees the new environment as foreign. And then obviously the inoculum contains immunocompetent cells which begin to attack host cells which are weakened by illnesses and conditioning. What are your risk factors? Again, stem cell source is well known, is going to be a risk factor for chronic GVHD. But for acute GVHD, it is debated. But by a large measure, most people will say yes, it is also a reason for acute GVHD. What about donor characteristics? We know that female to male graft is always a problem for both acute and chronic GVHD. We also know that if there is an older donor, it's going to cause you more GVHD. What about mismatched and unrelated donors? The degree of HLA disparity will increase your risk of acute GVHD, but it's not considered very significant for chronic GVHD. But this is again challenged because the biggest risk factor for chronic GVHD is always going to be acute GVHD. Patient age, we are lucky. A lot of our transplants happen under the age of 12, but if you are more than 12, your risk for chronic GVHD goes up. And again, then there are post-transplant things like DLI that will increase your risk of acute graft versus host. Severe infections during the peri-transplant period, very important cause of GVHD. It's to do with how your T cells polarize. And I will touch upon that briefly. Around the peri-transplant period, the immune homeostasis is broken. So there is a lot of cytokinemia that is going to cause you to have a higher risk of acute and chronic graft versus host disease. And we all know that when you use myeloablative regimen, you're going to cause a lot of tissue damage, and that is going to lead you to have more acute and chronic GVHD too. And Dr. Satya just touched upon it. Why is this topic important? Um, this is looking at causes of death in the BMT settings on the left. On the left, you can see a pie chart that shows that GVHD is the most common cause of death in post-BMT patients after relapse. On the right, you can see that the patient surviving more than 100 days, the all-cause mortality is about 29% at 1 year, with a non-relapse mortality of 12 and a chronic GVHD rate of about 35%. These are data sets from two different papers from two different cohorts, but the message is still the same. GVHD is an important cause of morbidity and mortality in our patients. How did we get in terms of understanding GVHD? This is a photo of Dick van Beckham from Netherlands, and what we now know as GVHD was first observed in 1956 in a murine model. Barnes and Luthi they demonstrated that, when irradiated mice were infused with allogeneic marrow and spleen cells, mice recovered from the radiation injury and dysplasia, but they developed diarrhea, weight loss, skin changes, and liver abnormalities, and subsequently died due to what they called secondary disease. At that time, there was some concept of self versus non-self antigens. And I alluded to Billingham in 1966. He beautifully showed that there are three crucial requirements for development of GVHD. First, the transplanted graft must contain immunologically competent cells. The recipient must be incapable of rejecting or eliminating these transplanted cells. And last, the recipient must express tissue antigens that are not present in the transplant donor. Thus, the recipient antigens are recognized as foreign by your donor cells. And this is a brief timeline of major BMT discoveries. As I said, GVHD was initially was described as a wasting syndrome in transplanted mice in 1956. In 1957, E. Donald Thomas and others started the first human BMTs, and there was universal mortality with high rates of infection, GVHD, and relapse. In 1970, HLA typing became more common, tissue typing became more common, and then we began to understand that T cells mediate GVHD and graft versus leukemia effect. And then GVHD prophylaxis with cyclosporin and methotrexate in dog models was first developed in 1980s. And in 1990s, we started to understand reduced intensity conditioning, stem cell mobilization, and Leo Luznik and group from Johns Hopkins started to use PTCY and naive T depletions in 2000s. And now we are doing much more of gene editing, other things as part of our BMT discoveries. When we talk about GVHD, it is important to know that there is an initiation phase. When you start conditioning, you lead to destruction of the epithelial cells and their integrity. And these damaged cells secrete uric acid and ATP that result in production of pro-inflammatory cytokines. And again, activate your DAMPs and your PAMs and your toll-like receptors. And basically, these signals ultimately activate your host antigen presenting cells that lead to donor T cell activation. Going into this, they usually say that you have about 3 phases. First is this host APC activation, then you have the donor T cell activation, and finally there is the cellular and inflammatory effectors. So again, conditioning regimens cause profound damage. They lead to inflammatory cytokines like IL-1 and TNF alpha in the first phase. And again, important to know that you're going to lose a little bit of microbiological diversity, and cause loss of beneficial microbiomes and due to tissue damage. And these are all important. And when these activated host APCs, because of the cytokinemia, activate the donor cells, you then get on Th1 and Th17 polarization, which activate CD4 and CD8 cytotoxic T lymphocytes that mediate tissue damage. And in phase 3, affected T cells, along with these cytokines, attack the epitheliums of skin, liver, lung, and GIT. And this is how basically your GVHD pathophysiology occurs. I wanted to summarize some key studies from the past as we look forward to with regards to GVHD and see what we can learn from them. These are very important studies from the past. Very early case reports in the 80s showed that cyclosporin or methotrexate or even cyclophosphamide, singly or in combination with other agents like prednisolone or IVIG, can be used, and they can limit how severe the GVHD was. Then cyclosporin and prednisolone was found to be better than methotrexate and prednisolone from some of the late 80 papers. But the most important study that came was by Rainer Staub. This is a recent picture of him from Fred Hutch website, where he actually randomized patients with a combination of methotrexate and cyclosporin, and comparing it with cyclosporin. And we can very clearly see that you have severe graft versus host disease, which is much lower in the cyclosporin methotrexate arm as compared to cyclosporin. But the chronic GVHD rate remains same. And again, this is very important that there was a trend towards an overall improvement in overall survival, but this benefit was restricted to the subgroup of patients with CML. Long-term survival is not improved in patients who did not have CML, and that partially explains the differences in outcomes in acute GVHD and chronic GVHD in those groups that were only treated with cyclosporin as compared to cyclosporin and methotrexate when we talk about outcomes. Again, very important study said cyclosporin with methotrexate is very important. What about Nelson Chow and group published this paper in NEJM? They did a randomization of 2 drugs versus 3 drugs, where they used cyclosporin, methotrexate, and prednisolone and compared it with cyclosporin and prednisolone. Again, they were bone marrow grafts. They were TBI with VP16 backbone. Again, you can see there's a little bit of difference between the acute GVHD rates, but again, you will notice that the infection risk with 3 drugs was much, much higher, and the overall survival was very similar between the 2 and the 3 drug regimen, although the initial GVHD was much lower in the 3 drug regimen. Again, 2 large multi-center phase 3 studies were performed to compare cyclosporin methotrexate with TAC and methotrexate. And TAC and methotrexate was found to be superior in reducing acute GVHD, but there was no difference in overall and relapse-free survival. Again, these were mud with bone marrow grafts. And again, it reduced the need for corticosteroid treatment after marrow transplantation without an increase in graft failure, relapse, or toxicity. It was found that tacrolimus was better, but ultimately it did not change the outcomes. And again, these were done in several studies where they randomized this. So ultimately, you can use cyclosporin or you can use tacrolimus with methotrexate. Your outcomes are not going to be that different. What about methotrexate 3 versus 4 doses? Again, this is a recent paper from 2023 from the Japanese group, where they looked at significance of omitting the day 11 mini dose methotrexate for GVHD after unrelated bone marrow transplantation. Very important to note, this is mini dose methotrexate, where they looked at 5 milligrams per meter square per day on day 1, day 3, day 6, and day 11, was found to be better in terms of GVHD control as compared to the 3 doses in this group. Again, so the importance of the 4th dose is there in this group, and we noted that there was a higher risk of severe acute and chronic GVHD in the omitted patient's dose. Again, important, this is a mini methotrexate. This is not the full methotrexate. What about Betty Hamilton and group from Cleveland Clinic published this paper very recently in Blood Advances, where they looked at TAC methotrexate versus TAC reduced dose methotrexate with mycophenolate for graft versus host disease. Again, it was a randomized trial. They looked at GVHD at both acute and chronic phase as their endpoints. 96 patients were randomly assigned to either full dose methotrexate or mini methotrexate. Again, full dose methotrexate was 15, 10, 10, 10, whereas the mini methotrexate was 5 on 3 doses along with MMF. Again, you can see that the incidence of grade 3, 4 acute GVHD with mini methotrexate was higher. The incidence of grade 3 with the mini methotrexate MM was higher, but there were no difference in moderate to severe chronic GVHD at 1 year or infections. Again, there were no differences in the 1 year relapse and overall survival between the two groups. And the non-relapse mortality was not very significantly different. Again, as you can see, there's no significant differences in relapse incidence, GVHD or relapse-free survival or overall survival between these two. I'm going to summarize all the key data. So for all the juniors out there, if you don't take anything home from this talk, take this slide as your takeaway. And so it will give you a background on why we do what we do when it comes to CNI and methotrexate or sirolimus-based prophylaxis. A large study from CIBMTR, nearly 4,000 patients with matched sibling and more than 4,000 in unrelated donor, actually showed significant inferior GVHD and survival outcomes with cyclosporin and MMF compared with TAC methotrexate, cyclosporin methotrexate, and even TAC with MMF in myeloablative transplantation, suggesting that there is an advantage of methotrexate over MMF. You can prefer 4 over 3 doses of methotrexate, especially if you are doing mini methotrexate as per the Japanese retrospective data. If you are doing TBI, then you prefer TAC sirolimus over TAC methotrexate because of the mucositis risk. But again, as I showed, mini methotrexate plus MMF with TAC in a bone marrow graft setting may be okay, but there may be a slightly higher acute graft versus host disease risk. This is a brief timeline of GVHD prophylaxis strategies. If you look below, you can see that in the 90s, late 90s, you saw ex vivo CD34 selection. In the 2009, ATG for MUD HCT was more commonly used. In 2017, alpha beta T cell and B cell depletion for haploidentical HCT was pioneered by Locatelli and group, and now that's increasingly used. And in late 2021s, again, you can see that abatacept, CNI, methotrexate for myeloablative mismatched unrelated donor HCT is becoming more accepted. And when you do it, you can also use cyclosporin, sirolimus, or MMF for your mismatched unrelated donor. And then there are some randomized trials which I will touch upon later on in this talk. Again, this is a refresher for people like me. I'm preaching to the choir, but there is also some refreshment here. Basically, acute graft versus host disease is classified as classic acute with onset if it's less than equal to 100 days after allogeneic HSCT. Late onset if it is beyond 100 days, and as recurrent if you have acute GVHD with onset more than 100 days after having had initial acute GVHD. And it is persistent if it is persistent beyond 100 days. Chronic GVHD has its own criteria, and it's usually with biopsy proof. And then there is an overlap syndrome where you have features of both acute and chronic GVHD. Again, pathophysiology is important. There is an initiation phase because of tissue damage. Your PAMPs and DAMPs are activated. It leads to host APC activation with donor T cell activation. This is the most important to understand that cytokines play a key role. And then there is the effector phase where your CD4 and CD8 cells are going to be your effector cells that cause GVHD, with TNF alpha being a very important mediator of GVHD in this group. Again, a refresher, We nowadays increasingly use MAGIC criteria, which is the Mount Sinai Acute GVHD International Consortium, wherein you stage your GVHD for skin, liver, upper GI, and lower GI based on your symptomatology and extent of involvement of skin rash and the type of skin rash you get, and bilirubin levels for liver. Whereas the upper GI GVHD is only up to 0.1 in terms of your staging, whereas the lower GI GVHD is based on your episodes of diarrhea as well as the volume. And remember, in children, we use mils per kg per day. But anytime a child gets severe abdominal pain with or without ileus or grossly bloody stools, it does not matter how much diarrhea they have, it is already stage 4. And then we look at the overall acute GVHD grading based on your skin, liver, upper GI, and lower GI staging and give an overall grade. And this is universally accepted as standard currently. Very simple algorithm for acute GVHD treatment. Any person who's been dealing with acute GVHD will remember this. If you have skin manifestation, you have gut or liver manifestation, you need to give them methylprednisolone. If you do not have gut or liver manifestation, if it's only stage 1 to 2 and it's less than 50% of skin involvement, topical steroid alone is enough. If it is stage 3 or 4, again, you will use methylprednisolone as your first line agent to treat. If you have treatment failure, then you'll move on to ruxolitinib. And again, then you have your third line panel of agents that are all there in this box. This is a society for cell therapy. So I will talk about the cells. Very important to understand how the cells work, what causes GVHD, and how they are activated. Again, very important. These are pathways of antigen presentation after allo-HSCT. Host alloantigens can be presented by host APCs, which is the direct presentation, or cross-presented by donor APCs after uptake of particulate host material, which is the indirect presentation. In direct presentation, donor T cells can potentially recognize allogenic MHC antigens on host APCs and may recognize host antigens that have been processed and presented to the host APCs. Alternatively, you can have the host allogenic MHCs or minor H antigens, which may be indirectly presented by donor APCs. Again, antigen presenting cells can influence develop of GVHD at multiple levels. Initial tissue injury and innate immune activation may trigger APCs within tissues and induce certain APC population, such as your dendritic cells, to migrate to draining lymph nodes. Migrating dendritic cells or other lymph node resident APCs trap these GVHD reactive T cells at this site for 3 to 4 days, where they induce T cell activation and may imprint a homing phenotype that actually permits selective trafficking of effector cells to your target organs. APCs within inflamed tissues may act to amplify the developing GVH response by further priming signals to T cells in situ by producing pro-inflammatory cytokines or actively recruiting T cells and other cellular effectors to this site. Again, a brief overview of your MHC presentation pathways of class 1 and class 2. MHC class 1, as you know, are found on most cell types in the body and present endogenous antigens to the cytotoxic T lymphocytes, that is your CD8 cells. Intracellular proteins are digested into peptides and transported to the endoplasmic reticulum. There, the short peptide fragments of about 9 to 11 amino acids are loaded onto MHC class 1 and transported to the surface, where they are presented to the TCRs of the cytotoxic T lymphocytes. MHC class 2 is the important effector when we important for your GVHD. These are only found on antigen presenting cells and present exogenous antigens to CD4 cells. In this pathway, extracellular pathogens such as bacteria are also phagocytized or endocytosed into endosomes, and they release lytic enzymes. The peptide fragments here are about 13 to 25 amino acid FS levels and loaded onto MHC class 2 and transported and present to CD4 cells here. This is very, very important for people to understand how T cell activate within the immune synapse between APCs and T cells. Three signals are required for antigen-specific T cell activation. Signal 1 comprises the presentation of antigen peptide in the context of MHC class 2, which is recognized by the antigen-specific TCR. Signal 2 involves the stabilization of this synapse through adhesion molecules and the generation of signals via your co-stimulatory molecules present on the surface of the APC and T cells. CD80-86 along with CD28 on T cells to generate activating signals. This is very important if we want to understand how abatacept works. And signal 3 is again very important. It's produced by the secretion of cytokines by the antigen presenting cells, which signals via cytokine receptors in the T cells in order to polarize them towards an effector phenotype. Again, like you have your co-stimulation, there is also co-inhibition of T cells. And essentially, it's a regulatory homeostasis for your T cells to remain in balance. You know about your co-stimulatory molecules. I just talked about CD28, but there are others like OX40, 41BB, and ICOS, which you may have heard of, which are co-stimulatory, have co-stimulatory functions. They're important for proliferation, cytokine production, differentiation, cytotoxic function, memory formation, and survival. And similarly, there are co-inhibitory molecules on your T cells like your CTLA4, BTLA, TIM3, and LAG3, which dampen the immune response. And this prevents your excessive immune responses. And in simple terms, if you imagine T cells are soldiers, co-stimulation is like an officer telling them to go and attack. Co-inhibition is like a general saying the attack is over, you calm down now. So preventing from being overzealous. So again, this is important to understand how all this that we learned as pathophysiology is used in novel therapeutics. You can work at the CD28 level, which I talked about, wherein your abatacept works as a blocker of the co-stimulatory signal 2. Then you can work at the cytokine receptor level, which is where your STAT signaling happens and where your even methotrexate MMF works. You can work at the integrin level. I will touch upon this. There are alpha 4 beta 7 integrin in the gut epithelial cells. That's how vedolizumab works. You can work at the T cell antigen level by ATG. You can work at the CD6 level, which is a T cell receptor marker for T cells with vedolizumab, which is some data showing that. And you can work at the TCR levels. But important to know how calcineurin inhibitors work. I will come to that in a bit. But more importantly, you can actually manipulate the donor graft. You can do CD34 selection, you can do alpha beta depletion, you can do donor T cells, work at the donor T cell levels by PTCY, which I'll also come to in a little while. And you can look at your microbiome dysregulation and apoptosis of target cells upfront to decrease the risk of GVHD. And then there are statins that are used, which may be of use, and I will come to that in a little way. So all this diagram tells you is the various pathways that you can use and how the novel therapeutics work. But it's important to look at this in the concept of how are these new drugs being used? What are the recently completed studies in acute graft versus host disease prophylaxis? I have put it in red box some key studies which showed significant differences. If you look at the BMT-CTN 1703 study, which was a post-transplant cyclophosphamide study, which looked at match-related and matched unrelated donors of 8 by 8 match, where they compared PTCY TAC MMF with TAC methotrexate. Look at the study group. The risk of GVHD was significantly lower. GRFS was significantly lower. What about abatacept? Again, looked at matched unrelated donor. They used abatacept with calcineurin inhibitor and methotrexate and compared it with CNI and methotrexate. Look at the GVHD rates here. 2.3 versus 30%. Small study, but very important. So this is where we are heading to. And there are other studies here which looked at vedolizumab, sirolimus, PTCY in various studies. So these are very key summaries of key studies. Again, this is a repeat of everything, but I want you to focus on a lot of things. We can actually manipulate the graft. This is where we should be to try and see if we can prevent GVHD, and this is what we do in Singapore. Again, this is another cartoon to say how do different drugs for GVHD work. I talked about other drugs like how you can work with ATG, vedolizumab, abatacept, even IL-6 receptor blockers with tocilizumab are useful. And then you have your JAK inhibitors, which will actually cause a decrease in T cell proliferation by inhibiting STAT. And there are aurora kinase inhibitors that have also been studied, which works similarly. But most important question for trainees and young doctors who are going through training is cyclosporin and tacrolimus. How do they work? They're basically cyclosporin complexes with cyclophilin, and tacrolimus complexes with FKBP12. And they inhibit calcineurin and block the dephosphorylation and nuclear translocation and transcriptional function of NF and FAT, thus reducing T cell function. Again, sirolimus binds to FKB12 and inhibits the mTOR to block your IL-2 mediated signal transduction, leading to cell cycle arrest in naive T cells. Its immunomodulatory properties also include, inhibition of antigen presenting cells in sirolimus and dendritic cell maturation, as well as preservation of Tregs. So sirolimus has a wider scope of action compared to tacrolimus. And I talked about vedolizumab. Basically, it works at the alpha-4 beta-7 integrin on T cells and MATCAM1 on endothelial cells in the gut, preventing T cell from entering the gut. Again, important, abatacept, I think more and more usage is being seen now. Basically, it's a co-stimulation modulator blocking the interaction between CD80, 86 and on the antigen presenting cell and CD28, as I showed again in signal 2, which actually attenuates your T cell activation and reduces the immune response. TOSI and aurora kinase I briefly mentioned. There are some HDAC inhibitors also that are being used. These are drugs that enhance the suppressive function of Tregs and modulate immune response, and those can be also considered. Are there any biomarkers out there that can be used? There are a few to diagnose and to monitor GVHD. Not going to go into much details in there. There are protein biomarkers that have been that are being investigated. There are microRNA and single nucleotide polymorphisms that can be monitored, and so are our oral biomarkers. Again, these are all being studied, and see if you can detect biomarkers. For the students and young doctors studying bone marrow transplant, I will say that the single most important biomarker currently that we are using for monitoring gut GVHD is actually stool calprotectin levels to see whether your GVHD is responding or not. Again, there was this paper published recently where they did the magic algorithm probability looking at two biomarkers, RECT3 alpha and ST2, which are responsive to tissue damage and crypt damage. And so basically after 4 weeks of treatment, these maps predicted a non-relapse mortality better than the change in clinical symptoms in all patients, and identified distinct groups with significant difference in non-relapse mortality in both clinical responders versus non-responders. And this was better than your clinical monitoring. So these are things, watch the space. We will learn more about it as more and more of these biomarkers come into practice. Again, understanding some drugs that we did not discuss before. I talked about cyclosporin and tacrolimus. But we need to know that statins may be having some role in GVHD. They basically primarily work by inhibiting T cell proliferation, decreasing the production of cytokines like TNF alpha and interferon gamma, and increasing the production of anti-inflammatory cytokines like IL-10 and IL-4. Some people are also using bortezomib, especially in combination with this chemokine blocker Maraviroc. And they found some data that showed that it works in some of the GVHD things. People will be using etanercept and infliximab as TNF receptor blockers routinely in GVHD. Abatacept I talked about. Alemtuzumab is also being used for steroid refractory GVHD. But again, be very careful when you're using alemtuzumab and TNF receptor blockers, because you're going to increase the risk of infections and viral reactivations very highly. Again, tocilizumab is similar, and basiliximab is an IL-2 receptor blocker. When the patient goes into chronic GVHD, there may be a role for rituximab, because remember, chronic GVHD is not just T cells, it's also B cell mediated. So there may be some role for these. Our pet talk is always post-transplant cyclophosphamide. Briefly, how does it work? There are two types of T cells. Basically, you have alloreactive proliferating T cells, which they have less aldehyde dehydrogenase, causing GVHD, and cyclophosphamide works in those. Those that are non-alloreactive with high aldehyde dehydrogenase, they are not killed by cyclo. So that is how post-transplant cyclophosphamide works. So this is an important way of understanding how PTCY works. These are recommendations from EBMT about GVHD. Again, if you're doing a match-related or a match-unrelated donor, they should receive GVHD prophylaxis with a calcineurin inhibitor plus an antimetabolite. And this is, everybody accepts that. This is a category 1 recommendation. If you're using tacrolimus or cyclosporin, you can use either of those. For unrelated donor transplants, the survival outcomes are very similar, as I just showed. Again, everybody accepts these recommendations. Methotrexate is the recommended antimetabolite for patients receiving MAC. Again, everybody accepts this. MMF can be used instead of methotrexate for patients receiving myeloablative only in cases where there is a contraindication for methotrexate. Again, so there is a lot of meta-analysis and retrospective studies saying that this is the third choice that you should be using. Again, there is comparative evidence for MMF versus methotrexate in the non-myeloablative conditioning does not exist. So there is no data to say that MMF is better. But rabbit ATG is again recommended by EBMT and can be used for both MUDs as well as match-related donor transplantation for patients to reduce chronic GVHD in some studies. This is one key study that I would like all our junior doctors and juniors to study. This is recently published in JCO. This is transplant data in leukemias as well as MDS. This is a randomized study in adults. More than 10,000 patients were in this study. Basically, there were patients who had matched unrelated donor with calcineurin inhibitors. There were matched unrelated donor with PTCY. There were mismatched unrelated donors with calcineurin inhibitors and mismatched unrelated donor with PTCY. If you can look at this one event-free survival, if you are a 7 out of 8 HLA match, it does not matter if you have PTCY in terms of overall survival and GRFS. So PTCY overcomes one mismatch and the outcomes are exactly the same. And even in your moderate to severe and grade 3-4 things, it seems that, a PTCY outperforms routine CNI based outcomes. This is very important. This is done in a large cohort of groups. So the importance of PTCY is demonstrated in this study. And this was regardless of patient ancestry. Basically, the benefit of PTCY was regardless of patient ancestry. So this is important if you do not find good matches. So a 7 out of 8 may be okay. That was one of the take homes if you're using PTCY. I will briefly summarize some key concepts without going into too much detail. Otherwise, I will not be able to finish. There is some data from Russia with the use of ruxolitinib with post-transplant PSI with very good results. There's a lot of data coming with abatacept with PTCY and sirolimus in even haploidentical transplant settings and mismatch unrelated donor transplant settings. Dose of PTCY, watch the space. There is some benefit of addition of thiotropine melphalan data from Satya's group and Gaurav's and others in India also showed that data that thiotropine melphalan may be good to improve outcomes. But the dose of PTCY is something that is being actively looked at. Recently, Dr. Moti came to Singapore and he was saying that they routinely have dropped the PTCY dose in their conditioning protocols to 40 per kg rather than 50 per kg. But I said, when is the data? He's saying it'll be coming soon. So watch this space. Again, very important, ATG and CAMPATH are important. We've been routinely using our doses based on body surface area as well as weight. But is that more important, or is the absolute lymphocyte count more important when you're dosing your patients with, especially with CAMPATH? These are data that are conflicting, but there is some emergence of data that is showing that, absolute lymphocyte counts maybe how you should dose your serotherapy. What about the use of cells for therapy for GVHD? This is very important cartoon. As we all know, Tregs are very important. They are actually available both as thymic Tregs as well as peripheral Tregs. In these peripheral Tregs have also important regulatory function in the presence of IL-10 and TGF-beta. And remember, your hypomethylating agents can induce peripheral Tregs. So does mTOR. So these can also have a potent immunosuppressive, immunomodulatory action. And these Tregs can deprive conventional T cells of the proliferative effect of IL-2. That is very important. That's how Tregs work. They also take away your highly expressing high affinity receptors for IL-2, which is the CD25. They can also hinder the co-stimulation of CTLA4 and its interaction with the co-stim molecules. And again, Tregs secrete IL-10, IL-35, TGF-beta, which are also, important to inhibit T cell activation. Briefly touch upon MSCs. I think some of my friends in India are doing MSC therapies. Again, it promotes a very good immunosuppressive and immunoregulatory environment by secreting cytokines, chemokines, growth factors, etc. And these are important. There's some data coming about importance of MSCs in immunomodulation, and also known to limit tissue damage and stimulate tissue repair. So if it is available, that can be used. Placental decidual stromal cells are also being investigated for their immunomodulatory mechanisms, particularly in graft versus host disease. Again, this is all important. And some of these decidual stromal cells also inhibit B cell maturation. So they may be important in chronic GVHD and also important in regeneration and repair. This is from a recent paper in Hematologica summarizing the prophylactic strategies being investigated and at what phase they are. So please go and read these papers. Again, there is in vivo T cell depletion with ATG, PTCY, sirolimus, along with calcineurin inhibitors. They are in advanced stages of randomized controlled trials. Ex vivo T cell depletion, again, alpha beta, pan T cell depletion, CD45RA depletion did have high rates of GVHD, but you can refine it. Again, CD6 depletion either with itolizumab or outside is important. Then there are the TRHT con add back, which are in phase 1, phase 2 studies. Again, regulatory T cell enhancements. There are ORCA studies going on which increase the amount of Tregs at inoculum level. And there are some studies about iNKT cells. Again, you can cytokine target with tocilizumab and abatacept. Again, they are in advanced stages of randomized controlled trials at the moment. A few words on chronic GVHD. Do remember the single biggest risk factor for chronic GVHD is actually acute GVHD, and it remains, a continuum wherein there is a spectrum of acute GVHD, overlap syndrome, and chronic GVHD. And again, intestinal mucosal injury is important, infection is important, intestinal dysbiosis is important, and there is bystander activation of T cells. And these dysregulated immune responses result in chronic inflammatory change, progressive tissue damage, and aberrant tissue repair with fibrosis that are characteristics of chronic GVHD. And remember, your key target organs are actually lung, liver, eyes, and skin. Very important for to know that STAT and ROC are very, very, very important when you're talking about graft versus host disease, chronic graft versus host disease. So as you can see, all the pathways lead to JAK and STAT activation and lead to chronic GVHD. So that's why your ruxolitinib is an important mechanism of inhibiting these JAK-STAT pathways. And these lead basically, JAKs are activated by cytokines, leading to phosphorylation and dimerization of the STAT dimers. And these activated molecules are then translocated into the nucleus to activate the transcription of genes and subsequently gene products involved in chronic GVHD things. ROC is also a very important ROC2. It's upstream of JAK-STAT pathway and it upregulates your TFH and TH17, leading to excessive production of IL-21 and IL-17, which causes a lot of problems in your GVHD. And this is actually downstream of TGF-beta, and connective tissue growth factor, which are all important pro-fibrotic processes. Therefore, ROCK2 inhibition may alleviate the pro-fibrotic process associated with chronic GVHD, and that's why there's a lot of uh, sales pitch for belimosidil, which is your ROCK2 inhibitor. I will talk very briefly about evolution of T cell depletion techniques. My favorite, this is a very nice paper that came out which talks about the various time points of how different ways of T cell depletion. So juniors can go and read this. In the 1980s, you did haplo with for SCID patients with soybean lectin rosetic, CD34 selection, Frank Aversa and all published in 1994, where you again megadose CD34 stem cell selection. Peter Lang and his group showed CD319 selection. And then there was obviously the Leo Luznik et al. PTCY approach. Then we talk about design grafts or better immune reconstitution. Again, there's various ways of doing this. We used alpha beta depletion as per Locatelli's group. Again, we also do CD45 RA depletion to add back memory cells, and I will show you briefly what we do. Again, Miltony machines are very important for these set of selective T cell depletions, where either you use Clinimax Plus or Clinimax Prodigy. And this is Stephen Miltony in his lab. Basically, the depletion of alpha beta T cells means you have these biotinated anti-alpha beta monoclonal antibodies and microbeads that actually remove the alpha beta naive T cells from your graft. So your graft is full of gamma delta, CD34 cells, NK cells, dendritic cells, regulatory T cells, but very little T cell dose into this. So these are the current ex vivo T cell depletion techniques. If you use CD34 selection, you get only stem cells. If you get CD3 depletion, you may get a little bit of NK cells along with the stem cells. If you do alpha beta depletion, you get NK, Tregs, dendritic cells, and gamma delta T cells. And if you deplete RA, you will get the RO, which is your memory T cells. What do? We take your peripheral blood product, 85 to 90%. We do alpha beta depletion, which will freshly infuse. We take the rest of the 10 to 15% for RA depletion and use them for frozen DLI. Most of our protocols, we aim for 5 to 20 millions per kg of CD34 and aim for a good log depletion of alpha beta and aim for a target of less than 25,000, which we're consistently achieving now. And we also add back about 1 to 5 million per kg of RO cells on day 0. We add 5 million if we are giving ATG. We add 1 million if we don't give ATG in our conditioning protocol. And then there are aliquots of 1 to 4 million per kg RO cells that we keep in case of viral reactivations or concerns of mixed chimerism. We will have frozen DLI banked or poor immune reconstitution. So I will come to the summary and conclusions. I hope my talk enhanced your understanding of GVHD pathophysiology, importance of donor T cells, cytokine imbalances, gut microbiota disruption. Again, I did not go into depths about this. There's some data coming about fecal microbiota transplants, which are important for your dysbiosis and also help you with your microbial diversity. We talked briefly about the different prophylactic strategies and their evolution. Touched upon, the various calcineurin inhibitors here and how important they are in combination with antimetabolites and with ATG or post-transplant cyclophosphamide. Increasingly, there are protocols that use both ATG and post-transplant cyclophosphamide by decreasing both the doses of both. And again, these are all data that we need to see in many studies to see what is the best way of maybe even having no GVHD at all in the future. We talked about new agents, abatacept, ruxolitinib, ROCK2 with belimosidil. Didn't touch upon ibrutinib. Again, B cell dysfunction is a big problem with chronic GVHD, and ibrutinib is something that works well in this group. I did not talk much about axatilimab, but again, one of those agents that are being used to try and reduce steroid use, have more treatment options, and to improve chronic GVHD management. But important to remember, PTCY with JAK is becoming important precision graft engineering, which we talked about, what we do. FMTZ we talked about is this. And the focus is slowly shifting towards personalized, risk-adapted prophylaxis. There is no one size fits all. There is some immune tolerance induction data that is coming, and microbiome biome preservation that is important to minimize toxicity and enhance quality of life post-transplant. So with that, I will thank you for having listening on a weekday. And I'm open to questions, which I'm sure my panelists will also help me with.
Thank you, Dr. Prasad. There are questions. People can answer questions, all attendees, which you may like to answer. Any questions, please?
So thank you, Prasad. Before we get some text messages on questions, I would like to ask you one question. So, in terms of GVHD prophylaxis, like there's a lot of data from adult which is coming where people are thinking of using PTCY even in match sibling and mud transplants. So, what's your take in pediatric setting? Where are we, and what are the thought processes, or what do you predict in future for pediatric match sibling donor and mud transplant? Would PTCY be introduced here also, or we are still happy with what we have got? Thank you.
Um, I'm never happy, Dr. Satya, truth be told. Um, so this is a very important point. I understand, please correct me if I'm wrong. Most of the grafts that are done in India are all, even if it is a younger donor, it is PBSC grafts. Is that right?
Yeah, so quite a more than 90% transplants are peripheral blood stem cells. Yeah.
So you are obviously we will have to look at our how best to mitigate the risk of GVHD, and I still will say this. I'm sure it will be your experience. The worst GVHDs I see are in your match sibling donor transplants. That this is my personal experience, because you will take your, you'll take it a little bit lower, saying, this is happening. But the horrible chronic GVHD, if you see it once, you don't ever want to see it in your life. So yes, I think that is where the future is probably going. The Russians are actually even doing alpha beta depletion of your match sibling donor transplants. So it is going to be a watch the space, use tolerance induction, bidirectional alloreactivity tolerance. And I think PTCY is so important nowadays that, people are using it for match sibling, match unrelated, mismatch unrelated, and they're using different, combinations with ATG as well as PTCY. I've seen some protocols where they use both.
Great. So I think there is one question. I'll just read it out for you. This is, what about 10 by 12 mud transplantation, DP DQ mismatch, PTCY or standard with PBSC graft?
I mean, this is a loaded question to me, I think. So the data is on a 7 out of 8 mud, where you see that 7 out of 8 versus 8 out of 8 in a PTCY background, where there is a disparity of one HLA antigen is okay. Now you're asking me about a class 2 mismatch. How important is that? Whether it is a permissive mismatch, we'll have to look at it. When conventionally we look at ABC, DRB1 and DQB1, right? But 10 by 12, maybe you're okay if it's a bone marrow graft. I don't know. But if it's a PBSC graft, I would be a bit worried if it is class 1 or class 2.
Yeah.
The important class 2.
Yeah, it's PBSCs. That's what the person has mentioned.
Okay.
Yeah, Dr. Anvita.
Okay.
Anyway, so I think PTCY is also a good option in this, it looks like. So there is another question, and this is pre-transplant immunosuppression used in mismatched unrelated donor. Apart from helping reduce rejection, will it help as GVHD prophylaxis? PTIS.
Separation with what? So that is the question, right? So
Yeah.
many places do pre-transplant immunosuppression with azathioprine and hydroxyurea. Suradej and I think some of my friends in India also do the pre-transplant immunosuppression with flu and Dex. So if you do flu and Dex, yes, you're going to lymphoablate. But the question is, it will be too distal to lymphoablate the graft T cells.
Yeah.
So that is my problem. And also remember that when you do lymphoablation upfront, there is always a rebound at times just before you before you infuse your inoculum, in which case you may actually be not completely obviating the graft rejection risk. So I
So
don't
yeah.
know if you have any other comments, Dr. Satya.
Yeah, there are a couple of quick fire more questions. So this is someone has asked, what's your take about post-transplant bendamustine as a new emerging option instead of PTCY? If you have any comment on that.
I have no comment on that. I don't know anything about it. I know
Yeah.
bendamustine is used as a lymphodepleting agent for CAR T, but I
Sure.
have not seen bendamustine being used much. There is some Chinese data on
So
bendamustine with fludarabine as a for
yeah.
double transplants. I don't
Yes.
know much about bendamustine
So
as
in pediatrics, there is no data, but recently one adult paper has come with Dr. Velu Nair from Apollo Hospital in Ahmedabad, where in elderly patients who cannot tolerate 2 doses of PTCY because of cardiac issues, they have given just 1 dose of PTCY and 1 dose of bendamustine, and they have published that paper with equal efficacy to PTCY conventional. So we still don't have much data in pediatrics, so we can't talk about it.
yeah.
The
So
last
it's an
question is,
important yeah.
yeah, what about single allele mismatch? Any role of PTCY with peripheral blood source? I think you have already answered
Yeah,
that.
I answered that. Yes.
And the last question is, in PTCY setting, starting CNI early, day -3 or day -1, will it reduce the GVHD rates?
No, I
That's
don't change the Hopkins regimen. You should not do that.
yeah.
I think there is a scientific basis of doing that. You want the alloreactive T cells to come to help you engraft, so you don't want to start your CNIs early in those groups.
So I have a comment here, if I'm permitted, Prasad.
Yeah,
Yeah.
So there's a data from France, and there's also from our center. We have almost used for more than 150 to around 200 transplants where day -3 cyclosporin with PTCY. It doesn't increase the GVHD risk, which we thought it may, because of the hypothesis which we had that it may dampen the allo reaction. Second, we see less haplostorms or the cytokine release syndromes. So it's a practice in our unit. We do use it from day -3, and it hasn't been derogatory in terms of GVHD, and it's beneficial in the context of CRS.
Okay.
So it's still very, very complicated, and like the risk of chronic GVHD is still there. I have used in few patients, and my experience, I saw a bit of chronic GVHD. So we need to publish whatever experience we have, and
Yeah.
that would help everyone. So the space is still open. There are a lot of new ideas of how to make it best. So I think we can finish here. Thank you, Prasad, for a wonderful session,
Thank you.
and thank you, Dr. Pankaj Abrol, for chairing this session. And I will hand it over to Dr. Sunil Bhatt for taking over to the next session. Over to Sunil. Thank you.